My name is Adrienne Johnson, and I did my presentation on obsessive-compulsive disorder. Obsessive-compulsive disorder, shortened as OCD, is considered one of the most debilitating mental health disorders within our society. OCD consists of 5 subtypes of the disorder, and OCD is thought to be mainly a genetic disorder, but has been correlated with cognitive behavioral theories. OCD is continuing to be researched to find more effective forms of treatment that have a lesser chance of relapse, and until a better method is found, combination therapy seems to have been proven to be the most effective therapy of our time. My paper was aimed at describing the 5 subtypes of the disorder, the epidemiology and etiology of the disorder, treatment options, and recent studies that have been done concerning the disorder. The DSM-IV-TR describes OCD as an anxiety disorder that is characterized by distressing, intrusive, obsessive thoughts and/or repetitive compulsions, actions that are clinically significant. OCD consists of 5 subtypes that have been created to explain the most co-occurring types of obsessions and compulsions, and these subtypes include contamination, harming, symmetry and ordering, pure obsessions, and hoarding. There are several assessments of obsessive-compulsive symptoms in the field today. The Dimensional Obsessive-Compulsive Scale looks at all 4 dimensions of OCD symptoms. The following tests all look at particular types of obsessions and compulsions. The Obsessive-Compulsive Inventory and its revision, the Padua Inventory and its revision, the Vancouver Obsessive-Compulsive Inventory, and the Schedule of Obsessive-Compulsive Compulsions and Pathological Impulses. Another type of assessment looks at symptom severity in OCD, which includes measures such as the Yale-Brown Obsessive-Compulsive Scale and its revision. The lifetime prevalence rates of OCD range from 1% to 4%, and has been found to affect 3% of our population. OCD is most commonly associated with Tourette's disorder and ADHD, but has also shown to be comorbid with other disorders. OCD is being increasingly treated as a disorder that is caused by genetics. Researchers have found that those with OCD have an abnormality in their basal ganglia and subparietal areas of the brain. More exclusively, OCD appears to affect the systems of the prefrontal cortex, such as those involving glutamate, dopamine, serotonin, and acetylcholine. Twin studies have also shown that the abnormalities in the brain can be inherited. Cognitive behavioral perspectives look at the idea that OCD can be a result of priming. Many people with OCD will do rituals as a way of relieving anxiety or distress and about their obsession. Because doing this rewards the person by relieving the obsession, it is likely to be repeated. Patients with OCD feel that they have a sense of control and responsibility over what happens, and this causes difficulty in ignoring thoughts. It has been found, however, that the way the parent or caregiver reacts to the child with OCD can maintain their OCD symptoms. Studies have found that 70% of most caregivers will accommodate, if not all or some of OCD symptoms in their child. This accommodation is likely to reinforce the child's behavior. Many psychiatrists and physicians will often prescribe patients with OCD tricyclic antidepressants, or more commonly, selective serotonin reuptake inhibitors, or SSIRs. SSIRs have been found to show a mean decrease of 20% to 40% in the OCD symptoms that a patient experiences. It has been found, however, that the dosage needed of SSIRs to treat OCD is higher than the dose given to patients with other disorders, and this is mainly due to the attempt to shorten the treatment time for the patient. The relapse rate from SSIRs have unfortunately found to be higher after the patient discontinues the drug. CBT, or cognitive behavioral therapies, have 3 elements of therapy when treating OCD. These are exposure, response prevention, and cognitive therapy. Together, response therapy and exposure therapy make up a therapy called ERP, which will teach patients with OCD that nothing bad will happen when the ritual or obsessive behavior is performed. Cognitive behavior therapy, on the other hand, teaches the patient that the thoughts that are causing anxiety are irrational and trains the patient to think more positively. Merlo et al. In 2009 did a study on family accommodation during CBT and found that within the families that responded properly to treatment, the patients who recovered less accommodation during the treatment reported better results during the post-treatment stage of therapy. The combination of CBT and medications have shown to increase the treatment effects of OCD patients. The two treatments that have shown to have better results in the combination than found in either have been used alone. But unfortunately, the effectiveness of combination of both treatments dissipates to about the same results of one treatment after 2 to 3 months. One study found, however, that more than half the patients that were treated with combination therapy were not found to meet OCD criteria within the next 5 years. There is little research combining therapies of OCD, although most psychiatrists and clinicians will recommend it to be used because of the initial effectiveness of treatment. In conclusion, OCD continues to be a disorder that is being researched, and more discoveries on the disorder occur every year. Although not all is known about OCD, it does not seem to hinder the success of patients with OCD. Patients continue to have success with CBT, pharmacological therapy, and combination of the two. As medical advances mature and receive more support for the treatment, OCD could become a better understood and less debilitating illness.